I am now going to demonstrate the tangential nail matrix shave biopsy. This procedure is done routinely for longitudinal melanonychia, and it is thought that this type of procedure is best to preserve the cosmetic appearance of the toenail after healing of the biopsy site. The reason that this is of importance is because the vast majority of longitudinal melanonychia lesions are benign in nature, and we would like to preserve the cosmesis of the nail plate as best as possible. With a skin marking pen, we have marked the nail to simulate a lesion of longitudinal melanonychia. These lesions are derived from the nail matrix, and they impart melanin into the nail plate. The diagnostic portion of the biopsy, therefore, must be in the nail matrix. What we are going to do is incise on the cul-de-sac of both the medial and lateral aspects of the toe and elevate the proximal nail fold to expose the lesion. The toe is anesthetized in your favorite fashion, and a sterile prep and drape, as is usual, would be done. We're now trying to elevate the fold by separating the cuticle from the nail plate. And we will then elevate across to reflect the fold so we can gain full exposure to the nail matrix. The reason we have to do this is to identify the most proximal aspect of the longitudinal streak, because the longitudinal streak, wherever it ends proximally, is the area of the biopsy. So when clinically we see the streak approached all the way to the proximal fold, we have to make sure that we reflect the streak to see how far it actually goes. So for purposes of this demonstration, I am going to mark the matrix under the fold to simulate a lesion that begins in that spot. It is up to the choice of the surgeon whether or not you want to do a nail avulsion to gain access to the matrix. However, underneath the proximal fold, the nail plate is very soft, and you can easily get through it if you decide to do a punch biopsy in this area. But since we are going to do a matrix shave, it is necessary to remove the nail plate, which we will do now. So assuming that the matrix lesion is back here under the fold, as marked, we then will take a number 15 blade, and what we are going to do is a horizontal tangential shave, taking the smallest slice of matrix tissue, literally one that you could see through and even visualize the blade. The purpose of that is to avoid the dermis of the matrix as much as possible so that the matrix epithelium can regenerate itself and form new nail plate as the lesion heals. And that very simply is done by tangentially going across the lesion Now that we have completed the cut, the specimen is elevated and placed on a cardboard so that it doesn't curl upon itself, and the specimen like that is put into the formalin bottle for dermatopathology analysis. Proximal nail fold is then brought back into position and can be anchored with 2 simple sutures in either side and a topical antibiotic ointment dressing applied. Follow-up would be anywhere between 5 and 10 days, and the procedure is completed. I am now going to demonstrate the punch biopsy procedure for longitudinal melanonychia. The purpose of this procedure is to provide the pathologist with the diagnostic portion of the lesion so an accurate diagnosis can be made. The lesion is always in the matrix portion of the nail bed. The punch biopsy is a procedure which has advantages of being relatively easy to perform, and it results in rapid healing. As you can see, we have marked the nail to simulate a lesion of longitudinal melanonychia. The purpose of the punch biopsy is to get the diagnostic portion of the lesion, which is always in the nail matrix. The punch biopsy has to be done in the most proximal aspect of the streak. Wherever the streak ends has to be identified, and that is the point at which we will do the punch. There is good evidence that a punch of
I need you to say there is good evidence. Keep your finger right there. Go ahead.
There is good evidence that a 3 millimeter punch will not cause damage to the matrix sufficient enough to cause a cosmetic issue with nail regrowth. However, it is not a good idea to promise a patient that they will have no disruption in nail growth. The 3 millimeter punch can be used safely without significant worry for a nail cosmetic problem. Using a packer, we're going to reflect the nail fold to identify the most proximal portion of the streak. And as we could see in this demonstration, we do not have the need to reflect the fold. Now we're going to take our 3 millimeter punch and orient it 90 degrees to the proximal aspect of the streak, and we're going to insert and do the punch right to the periosteum of the phalanx. The specimen is very firmly adherent to the periosteum, and to loosen it, we gently move the punch back and forth and then excise the specimen. The defect is then covered with a topical antibiotic ointment and a sterile dressing, and the procedure is concluded. To eject the specimen from the biopsy punch, you can use a sterile cotton tip applicator to insert it into the hollow handle to push the specimen out, or you can use a punch biopsy device that has a plunger incorporated into the handle.